Hi, my name is Kim Schmidt. I am the CEO at Sherbrooke Community Center and Central Haven Special Care Home. I'd like to begin by inviting us to think not just about what we provide in long-term care, but why we provide it and for whom. Across Canada, we are united by a common goal: to ensure that older adults living in long-term care experience lives that are meaningful and dignified. Over the past decade, three important movements, Choosing Wisely Canada, Healthcare Excellence Canada's work on antipsychotic use in long-term care, and the Eden Alternative, have each contributed powerful insights towards that goal. While they come from different places, they are deeply connected by a shared philosophy. Care should be person-directed, evidence-based, and rooted in respect for human dignity. Choosing Wisely Canada asks us a deceptively simple question: is this test, treatment, or medication truly necessary? In long-term care, this challenge is especially important. Residents are often living with frailty, dementia, or multiple chronic conditions, and they are particularly vulnerable to interventions that may offer little benefit or may even cause harm. Choosing Wisely reminds us that more care is not always better care. Sometimes the wisest choice is to pause, reflect, and prioritize what truly improves quality of life. This question sits at the heart of Healthcare Excellence Canada's work on reducing the potentially inappropriate use of antipsychotic medications in long-term care. Nationally, they have set a clear and ambitious aim: to reduce antipsychotic use to 15% or less in all Canadian long-term care homes. This goal is not about hitting a number for the sake of performance. It is about setting a shared expectation that medication should be used thoughtfully, appropriately, and only when the benefits clearly outweigh the risks. For many years, antipsychotics were often used to manage altered responses associated with dementia, frequently without diagnosis of psychosis and sometimes without full consideration of the harms. The national antipsychotic initiatives challenged us to do better, to look closely at our data, to learn from high-performing homes, and to recognize that improvement is possible across every province and territory. The 15% goal serves as both a benchmark and a beacon. It tells us what is achievable, and it keeps us focused on residents' well-being rather than on convenience or habit. Importantly, this work is not anti-medication. It is pro-person. It asks teams to understand the meaning behind altered responses, to assess for pain, fear, loneliness, boredom, and unmet needs, and to respond with skill, curiosity, and compassion. In doing so, it brings Choosing Wisely principles to life, avoiding unnecessary treatments while engaging residents and families in shared, values-based decisions. And this is where the Eden Alternative provides an essential humanizing foundation. The Eden Alternative reminds us that many of the challenges we see in long-term care, distress, agitation, withdrawal, are not simply clinical problems to be managed, but human responses to loneliness, helplessness, and boredom. Eden calls us to create homes where relationships matter, where daily life has meaning, and where people continue to experience joy, purpose, and connection. When those elements are present, the need for antipsychotic medications often diminishes naturally. When we weave these three approaches together, a powerful narrative emerges. Choosing Wisely gives us permission and responsibility to question practices that may no longer serve residents well. Healthcare Excellence Canada gives us national alignment, evidence, and the shared 15% goal to guide improvement. And the Eden Alternative gives us the culture and the values that make sustained change possible. Together, they shift us from controlling altered responses to understanding people, from routine-driven care to relationship-directed living, and from risk avoidance to thoughtful, individualized decision-making. They remind us that reducing antipsychotic use is not a standalone initiative, but part of a broader transformation in how we think about aging, dignity, and quality of life in long-term care. As we move forward today, I invite you to see the 15% goal not as a finish line, but as a reflection of our collective commitment to do less of what causes harm and more of what helps people truly live well. Ultimately, our goal is to ensure medications are used purposefully, eliminate unnecessary or appropriate use, and enhance well-being. Thank you.
Hi, I am Deb Schick, the leader of professional practice at Sherbrooke and the administrator at Central Haven. I'd like to thank Kim for her opening remarks of this education session, and I'm going to continue on with the rest. So I want to start with our big goal, which is to reduce the inappropriate use of antipsychotics without to less than 15%, which has become our national goal. And just looking at our numbers from LTCF recently, Sherbrooke is at 23.4%, and Central Haven is currently at 5%. So that means we have a few elders that are considered chemically restrained. There are indications within LTCF that do not necessarily meet the recommendations for appropriate use, such as our folks that have acquired brain injuries or have different mental health conditions that may not be showing. So this can be reflected in these numbers, but as we move along and understand our residents better as we go through this process, I think that we may be able to remove some of these medications or decrease them and create quality of life for people. We have done that at Central Haven, and I have a few stories throughout this presentation to share with you. I have a couple of definitions for you about pharmacological restraints. Means to use a prescribed medication to control a person's behavior, including to facilitate care and or to decrease altered or protective responses. Most of the medication used as a pharmacological restraint has a sedating effect, such as antipsychotics, sedatives, hypnotics, and antidepressants. And that, excuse me, is from the Registered Nurses Association of Ontario. GPA also has a definition, and we've actually used this definition in our policy. Medication to control behavior or restrict freedom of movement, not treat a medical condition. The order for a pharmacological restraint must include the following: the medication chosen, the stated intent, the duration, frequency, dose, and the review date. All of that information is also required by the Ministry of Health in the guidelines, program guidelines for long-term care. I wanted to spend a few minutes just talking about our journey. We have done many, many years of research and education with staff and with our nurses. We have been working with families to support them in caring for their family members who are living with dementia and the challenge that can be for them. We changed from PART, which is Professional Assault Response Training, to GPA, which is a much gentler approach, to looking at risk, to looking at our falls education, and we've had lots of restraint education as well. We don't have anyone physically restrained in either of our homes and haven't for many years, which is really great. The Ministry of Health, we also look at the long-term care guideline, or the long-term care quality indicators that come out quarterly from the work that you do on the LTCF assessments. All of those indicators, there's 6 of them, we look at every quarter, and we have to respond to them with the ministry if we are over threshold. So they have been reducing the targets over time as we have been educating. So many of the targets that the ministry have set, they are reducing. And I suspect very soon they will reduce from 23.4 down to maybe 18 or 19. It'll be a slower progression. I don't know if they'll jump right to 15, but that could happen. Dementia inclusive was how we started looking at our folks that were what we would consider environmentally restrained because they were behind a locked door. And we have now become the Sherbrooke inclusive community where people have the ability to enjoy all of the things that Sherbrooke has to offer. And this is ongoing work, and it is very individualized work. So if we look at where we want to be, we want to have quality of life for both our residents and staff, and that means that residents have the ability to make choices to live their lives the way they want to, and that staff are not having to force residents to do things that they don't want to do. We have really increased our engagement with within our community for all of our community members, and we're continuing to work on that as we move into the citizenship model. And that has increased our family engagement, it's increased our volunteer engagement, and that's what we want. We want more families involved in a very positive way, and we want more volunteers involved as well. And this will all occur with education and a reduction in the use of pharmacological restraints. So if we look at medication, medication can be such a helpful tool when we are looking at specific symptoms. If someone has pain, pain medication helps that. If someone has depression and anxiety, antidepressants can help that. If someone has hallucinations and delusions that are disturbing to them, that cause them stress, an antipsychotic can help with that. The first step of using these medications is to clarify what symptom you are trying to manage by using a particular medication. We have to have a low threshold for a trial of a scheduled pain reliever if pain may be a contributor. And we can use the PAC/SLAC or the PAIN-AD to help us identify when pain is occurring and how we can manage it. Some facts about antipsychotic medication is that they are generally effective for hallucinations, delusions, and they're often used in major depressions as an adjunct treatment. There is potential effect for agitation or aggression, although this is still these medications can actually increase aggression and agitation in some folks, so we have to be very careful of that. They are absolutely ineffective if someone is calling out. If they have insomnia, it will help them fall asleep, but the side effects are significant for them during the day. It will not stop wandering or exit seeking. Eating inedibles such as soap, they won't help with that. If people are hiding or hoarding items, will not help with that. Fidgeting, tapping, clapping, it's not going to stop those physical movements either. Sexual inhibition, and it's not going to stop someone from having inappropriate elimination somewhere in the hallway, in another person's room, in a plant. We've seen it all. It's not going to help with that. We're not saying that antipsychotic medications don't have a place, because they do. They are used very well with people with schizophrenia and bipolar disorders, but most are overprescribed. And so that's what we're looking at is, are we overprescribing these medications? And how can we ensure that we are using them correctly and safely for our folks over 65? So if we look at the downside of antipsychotics, Health Canada has warnings, FDA has black box warnings regarding the use in individuals with dementia. There is an increased risk of death, 1.5 times as much. There's an increased risk of stroke. There's an increased risk of pneumonia because they're not as active. They're not moving as much because they're sedated. We need to have informed consent related to this, and people need to understand that this is the risk of those medications. Other important adverse effects are that it increases our fall risk. And we see that. And when we have reduced the medications, our number of falls actually decrease, which is a great correlation to show to staff. It can cause restlessness, drowsiness, dizziness. Extrapyramidal symptoms can be significant as well. It can cause weight gain, increased blood pressure, increased cholesterol. It can increase blood glucose, cause postural hypertension, which then leads to dizziness and falls, and tardive dyskinesia. So I know we've talked about this, but I just want to make sure that everyone understands that these medications are not effective for calling out, wandering or exit seeking, trying to leave, hiding or collecting items, sexual inhibition, insomnia, eating edibles, fidgeting, tapping, clapping, inappropriate elimination. They don't work. They will not help with that. The behavior will still be there. The response will still be there. They'll just be maybe a little slower to do it. So sedatives and hypnotics, they absolutely have a place. They should be used for short term. They are highly addictive and difficult to stop. And there's many warnings about them for our population of older adults. So we often talk about this in the Eden Alternative, is that we are world makers here at Sherbrooke and Central Haven, and it's really important that we remember that we are really bringing the world into our elders and trying to provide all the things that we have at home inside of Sherbrooke and Central Haven. Nancy Fox said, "We have created worlds where people live with dementia, where people living with dementia do not want to be, and then we medicate them to keep them there." And I have thought about this particular quote many times, and I am so happy to see us be an inclusive community where people are able to experience all that Sherbrooke and Central Haven have to offer. So how do we create a better world for elders who are living with dementia? So we need to shift our thinking from behaviors to unmet needs. Altered responses are an attempt to communicate an unmet need. If you think about this, how would you feel if you were cold and the only way you could get someone's attention was to call out? And no one came to you except to give you a medication, but no one put a blanket on you or put a sweater on you. And so now you're cold, but now you're drowsy and you can't respond, but you're still cold. You're still uncomfortable. So you still call out, which then someone comes and gives you more medication. And you have more and more medication to the point where you can't call out, but you're still cold. When really, if we'd have just put on a sweater or wrapped in an Afghan, we could have stopped the calling out. And we need to think about each of those unmet needs and really be good detectives and try and figure out what is the resident, the elder, trying to tell us. So let's talk about the side effects of our creative approaches when elders' needs are met. They have joy, which is great. They have well-being, which actually increases the immunity that each of us have. Because we have well-being, we have happiness for what's happening around us. They have excitement because they're involved in what's happening in our community. They have dementia, so they start to remember things. They learn things, which is great. They're able to connect with their family. That is what success looks like for our residents and elders. So again, the risks, the side effects of antipsychotic are death, heart issues, stroke, increased confusion, which is not what we want for our folks that have dementia. They are confused. Higher risk of falls and fractures, severe muscle stiffness, which is painful, weakness in arms and legs, dizziness, and loss of balance. We don't want that for our folks. Some people have difficulty talking. They have agitation and anxiety. They have constipation. They have Parkinson's disease-like symptoms, GI upset, nausea, and vomiting, hyperglycemia, blurred vision, orthostatic hypotension or hypertension, body temperature fluctuations. Significant side effects for people. Cheryl Carlson, who is a PISA's educator, said, medication is part of the care plan. It is not the whole plan. And I think that is something we really need to look at, because oftentimes the medication is started and then nothing else is looked at. And I'm hoping that our least restraint process for pharmacological restraints will help us to look for those unmet needs and see if we can't solve some of those. So this study from Most and his team, they reviewed almost 100,000 veterans in the United States and found these startling numbers for those over 65. Haldol causes 1 death in every 26 people. Risperidone causes 1 death in every 27. Olanzapine causes 1 death in every 40. Quetiapine causes 1 death in every 50. Those are significant numbers that we need to think about. I know there are significant challenges that nurses face due to us looking at this, and we want to support you. We know there's pressure from CCAs to use PRN medication, but you need to remember that CCAs don't have the skills or the knowledge to direct the use of these medications, and you should not be taking direction from a CCA. You should be making your own assessment and figuring out why something is happening for someone, and just listen to them, hear their struggles and concerns. But they don't need to stay in that situation. Use the GPA stop and go, direct them to leave and reapproach later. It is also supporting the teams to have someone else intervene when needed. And I know there is lots of pressure from families of elders. A PISA's assessment is needed where everyone's voice is heard, including the residents and their family. And PISA's is really something that I think can really help us to understand the elders' past and some of their current struggles. And I think that involving family and residents when they can certainly help us and lead us in the right direction. So what can we do when we face these challenges? I think one of your best options is to always focus on pain, because pain control is often missed in many cases. So we need to really put our focus more on pain. If you sit on your right hand and don't move from now, just do that. And put your hand under your butt and sit there and don't move. Families have often been involved with caring for their loved one, either at home or in another care setting. It is important to listen to them and include them in our assessments, especially when a PISA's assessment is being completed. How's your arm? How's your hand? Any pain? Can you tell me about it? Imagine that you can't. What would that be like? That's what our residents face some days. So pain is often undertreated in elders with dementia. It's a known fact. They are unable to tell us when they have pain. We need to be good detectives and watch for signs of distress and then treat aggressively. 2 plain Tylenol are not going to help someone who's got osteoarthritis. They're going to need probably a gram of Tylenol 4 times a day to try and manage their pain. Arthritis and other muscle pain, like if they're on a cholesterol-lowering medication, and they're in their 80s, we need to really look at why they're still on that, because that particular medication has one of the side effects is significant muscle pain, and especially the legs. So I can't imagine having a medication that actually causes me to have pain. We need to look at, is there a history of pain? There's also higher pain medication usage historically on third and fourth than first and second, although that is changing as the population changes on first and second with more of an inclusive community. For our folks with dementia, the PAXLAC-2 pain scale can be very helpful. It is a pain assessment scoring tool that assesses multiple indications that could be expressions of pain by an elder. Facial expressions, active body movements, social personality mood, psychological or physiological changes with eating, sleeping, changes, vocalization. So all of those things can lead us to the possibility that someone is in pain. And if you do the PAXLAC-2 a couple of times in a day or a couple of times in a few days, you can actually see, oh yeah, there is something here, and we probably need to manage this pain differently. And so, start slow. That's the plan. Start slow, start low, and see where it takes you. But don't be afraid to go higher. So if you start with plain Tylenol and it has minimal effect, move up to extra strength and see if that helps. And the other thing is that if we have pain assessments and we can show, yes, this person is having pain, and then we start a pain treatment and it doesn't seem to be meeting their needs, we can do the PAXLAC-2 again for a couple of days, and then we can show the physician. And so there's data there for them to look at, and they go, okay, like let's increase this, let's try something else. I wanted to tell you about a success story we had at Central Haven. A gentleman named Stan was coming to move in with us, and he was on quite a lot of antipsychotic medication. And Marla had a long discussion with his daughter, and it explained that would be something we would be looking at to reduce or discontinue those medication. And the daughter was, yes, please take him off it. We don't know why he was put on it. We don't understand. He can't walk. He was wheelchair bound. He was not able to communicate with his family. He was not able to eat on his own. And he was not able to communicate with his family. And so before he moved in, we had discontinued that medication because the family did not want him to be on it. Within a few days of being in his new home, he was walking with his walker, with his daughter, and with staff, and he was talking with his daughter and able to eat by himself. So the side effects of these medications are significant. The other thing is that many of our folks are coming to us from hospital. And if we go back and we look at why was that medication started, it's often started in hospital, and there seems to be like a cocktail of Seroquel, risperidone, and Zopiclone that people are put on in the hospital so that they sleep, because they're not supposed to get out of bed. And sometimes people have a delirium when they're in the hospital, and so that can be a necessary treatment to give them an antipsychotic to help them with that delirium, treat whatever's causing the delirium, but we don't need to keep treating the delirium that's no longer there. And so that's when we need to take those medications away. There is actually no evidence that stopping them cold turkey causes any harm. There's no evidence, but many physicians are wanting us to be a little bit more cautious, and so they will step it down, and that's fine as long as we're having a continual decrease. If we're not using a PRN, we need to get rid of it because it's counted. So we need to remove it. And if we're not using it, that's great. We should just not have it on our system, because if it's there, it could be used, and we don't want that, because if it's used unnecessarily, it puts that person at a great risk of a fall. I have included the references I've used for this presentation. I believe you can click the link on these, and you should be able to access. If you can't, just let me know, and I'll provide all of these articles if you're interested. Some of them will be put into a special file for you so that you can access them and increase your understanding of these medications. Thank you for your time. The next presentation will be on the procedure for pharmacological restraints. Thank you.